you're 75 or 80 years old, it will be usually difficult to take more than 100 milligrams of cannabinoid a day. Some patients can, but some can't even get to 100 milligrams a day. That's CBD plus THC. The age of the patient is extremely important, and like Mary Lynn said, I always start low and go slow and find out what the maximum tolerable dose is. There's a little trick I use. If somebody gets too much psychoactivity at a particular level and they were able to tolerate a lower level, I go back down to that lower level, hold at that level for several days to even several weeks to allow the body to develop tolerance, which it does to cannabinoids, and then I can often begin the titration upward again in a slow and not go up quite as fast as I went up before, and patients will be able to get past the dose that they previously were not able to tolerate. So age plays an important role in how much and where I start. I skipped over the cytochrome P450. The other thing that I do routinely is I take all of the medicines, especially the chemotherapies that patients are taking, and put them into a drug interaction checker. And the drug interaction checker I use is from Medscape. And Medscape, most of the drug interaction checkers that are available on the internet don't have cannabinoids, either THC or CBD included. But CBD to a greater extent and THC to a lesser extent will inhibit enzymes in the cytochrome P450 system that are responsible for metabolizing drugs, including the chemotherapies. So is it important to pay attention to this? I think so, because some of the chemotherapeutic agents that are metabolized in the P450 system are highly toxic. And if you administer those drugs along with the cannabinoids, because the metabolism of those drugs is blocked by the cannabinoids, blood levels of the chemotherapies will go higher. So you might say, well, that's a good thing. They'll get a bigger dose and have a better chance of killing the cancer. But it turns out that the side effects of those chemotherapies are also accentuated. So I've seen patients who were not paying attention. They were trying to use cannabis and having a lot of side effects, and they were using the CBD and THC in conjunction with their chemotherapy, and when I made accommodation for the cannabis with the chemotherapy, some of those side effects and toxic symptoms reduced or went away. So sometimes if the drug is highly metabolized in the liver, and it's a drug that's, say, given every 3 weeks, I'll have the patient withhold their cannabinoids for 36 to 48 hours before and after the IV administration of the drug. Even though there is this potential for interaction, there is a literature that supports the synergistic activity of cannabinoids with chemotherapy and radiation. And it's been shown in both of those modalities, those therapies, that the synergistic effect, meaning that the sum of the parts is greater than the actual arithmetic. 1 plus 1 is 3 or 4 or 5. So you get an enhanced effect. So it seems to work pretty well for the intermittent therapies. When patients have a drug that's metabolized in the P450 system that they're taking every day, and they want to take the cannabinoids every day, I strongly encourage them to have a conversation with their oncologist. It's always better to have everybody on your team. I don't like to work with patients who are using chemotherapy and cannabis, but they're not telling their oncologist what they're doing. It makes it very difficult to manage all of the nuances of good therapy. If you have too many cooks can spoil the stew, so they say. So it's better to have just one medical force working in your behalf. And so I do encourage patients to have this discussion. It's not always possible because I work with patients from all over the world. I do my consultations by Skype primarily. I have patients from Europe, South America, Australia, all over, and patients can't always get the medicine they need. Patients often are living in a country where cannabis is not legal, and they are using it surreptitiously anyway, and so they can't discuss it with their doctor. So it sometimes requires a lot of consideration to figure out how to best do that. So Dr. Sean McAllister's lab has also has a researcher that works in the lab named Eric Singer, and Dr. Singer did a very interesting experiment. He grew cancer cells in a petri dish, in a plastic dish, and then treated those cells with CBD, and found that the CBD killed the cancer cells. I believe he used glioblastoma cells in this experiment. And then Dr. Singer pre-treated the medium that these glioblastoma cells were growing in. He pre-treated with vitamin E, and then put the CBD in, and lo and behold, the CBD no longer killed the cancer cells. So it turns out that as I said earlier, CBD can affect the ID1 gene and slow tumor growth, and also slow or retard metastasis. But CBD also has a direct killing action on cancer cells, and it appears that this killing action is manifest by oxidizing the cancer cells. So CBD, even though CBD is a mild antioxidant itself, it induces in the cancer cell a pro-oxidative state. So if you have a lot of antioxidants in your system, there's a strong likelihood that those antioxidants will diminish CBD's ability to kill cancer cells. So when I discovered this research about 14 months ago, so I decided that there were some supplements that look like they would be valuable. People people take curcumin and melatonin and medicinal mushrooms. There's a lot of research showing that those supplements may be helpful for cancer, but it turns out that when you're using the cannabinoids, those supplements may be counterproductive. So my initial strategy was to give those antioxidant supplements at bedtime, which places them as far away as possible from the CBD, and I'll tell you the protocol later, but that bedtime is the farthest distance in time from the CBD. But I have seen patients who have not responded, and I'm just telling you what I do. I don't have all the answers. I don't know how to cure cancer. I don't know how to treat every patient effectively. I have patients that don't make it. I have patients that I start with late in the game and they don't survive. I have other patients that start early in the game and don't respond to the cannabis. It's not hard science yet. So I'm still learning, and I want to do everything that I can possibly do to help all of my patients. So I've evolved in my thinking about antioxidants, and more recently, I'm suggesting that patients who are relying strongly on CBD killing their cancer, that they eliminate all supplements with antioxidant activity, and let's see what we can do with the cannabinoids. In fact, I have a patient that I just emailed earlier today, a woman, an 82-year-old woman with breast cancer, who I started treating in the summer of 2016, and her tumor marker is increasing. So what we're doing is not working. My philosophy is, if what you're doing isn't working, you better do something else, because insanity is to continue to do the same thing and expect a different result. So this one has been on the supplements that for all of this time, and her tumor marker is going up, and so I have to change everything. So she did best when she was taking much more CBD than THC, and somehow her tumor marker started to go up, and we changed it and gave it a balance 50-50 CBD, THC. Tumor marker still going up, so I just totally changed the protocol to 1 part THC to 3 parts CBD, stop any supplements that might compromise the CBD, and let's have another go at it. You can't just keep doing the same thing and expect things to change. So as time goes on, I'm becoming more averse to having antioxidants in the mix when CBD is being used. So and it's really important to use whole plant extract and have the full entourage effect. There are, we work primarily with THC and CBD, but there are other cannabinoids in the whole plant that have anti-cancer effect, and there are terpenes, and I'll show you a list in just a minute. There are about 10 terpenes that have documented anti-cancer effect. And someone asked a question of Mary Lynn, I think, about hemp CBD, and one of the things that I would add is that hemp CBD does not have hemp CBD is anemic. It doesn't have an entourage. There are no full spectrum of cannabinoids that go along with the CBD like you see in ACDC. Even ACDC has a little bit of THC, maybe 1%, but you're not going to see that in hemp, and so for that reason, I believe that CBD derived from a cannabis cultivar is going to be more powerful than a CBD derived from a hemp cultivar. Now, as I say, I have patients from all over the world, and many times cannabis-derived CBD is not available, and so if there's no other option but hemp-derived CBD, they have to use that, and I can't tell you with certainty that the hemp-derived CBD doesn't work. I don't know that for a fact, but I don't. It's not something that I choose preferentially. It's something that I only choose deferentially. So I think whole plant extracts are important. So the whole plant has about 110 cannabinoids, and the number that I've settled on for the terpene number, even Mara mentioned it was somewhere between 1 and 400. I just went down the middle and say 200, but the total number of compounds